we have come a long, long way in ultrasound from the beginning. And so as I was putting this together, I'm like, well, we're going way back in time here. So we need to do maybe a little sci-fi viewpoint on it. So as I started putting this together, I go, okay, well, we have to play the role here to get everybody in the mode of being in the evolution of POCUS. So everybody's heard of Father Time, right? That's my husband. He's sitting over there. He's been my, right there. We grew him some hair. So everybody's heard of Father Time. And so he's been with me throughout the whole process of learning ultrasound. And as Dr. Durr said, I've been performing ultrasound since 1979. And Gulf Coast is in their 40th anniversary this year. So I thought, well, we go back a long time. And so if he's going to be Father Time, I have to be something to take you back into this journey today. So for today, I'm Mama Ultrasound. So are you all ready to go back to the journey? I'm going to take you back in time and see how we all got to where we are right now. So in the beginning, a long, long time ago, before most of you were born, ultrasound was introduced to the medical community. 8-foot size systems, full body water baths, onto static compound scanners, none having real-time imaging. And then eventually we got to the first real-time scanner with large size transducers, and then large size systems that weighed 500 pounds, and we had to roll these through the hospitals. So obviously these were not conducive to doing bedside portable ultrasound. So fast forward into the 90s, and we now have smaller cart-based systems that are easier to maneuver. They have great image quality, lower cost, and even to our handheld systems that we can put in the pocket and make this technology more accessible to be able to rapidly diagnose our patients in emergency setting, critical care, and other applications. So we've run a long way in technology to get us to where we are today. So we're going to take a walk and take a look through just what we have done through the years. Oops, sorry about that. So as the systems became smaller and improved in technology, that also involved the transducer technology, because you got to have the right transducer to be able to get an accurate exam. Back in the 1970s, when they developed the first real-time systems, if you want to call them real-time, they have very, very low frame rates. So as you're scanning, things move very, very slowly. You really couldn't get a true real-time image. These were the transducers that we had. And so you can see they're very large size, similar to a linear array, although they were a real-time system with the transducers and units within the ultrasound probe. And these systems, when they were first introduced, were primarily for OB. So the first system was in 1958, and it was primarily for OB applications. But over time, we added in abdominal applications as well. But you can see how tough it would be to scan an OB patient, especially in late pregnancy, with a linear array transducer. You're going to lose contact, and images weren't also great. In the 1980s, we introduced the mechanical transducers, where instead of having units of elements within the probe, we had actually rotating transducers that were housed within liquid. And so as you're scanning, that liquid evaporates. So there was always maintenance to that, where you're always filling the transducers. And of course, anything mechanical is going to have a higher risk of breaking. But the advantage of these transducers is that they were a bit smaller than what we had in the 70s, and they had a smaller contact area so that we could evaluate the heart and different areas in the body with much greater ease and also better image quality. One of the other downsides of mechanical transducers is that you had a 3 megahertz transducer, but if you needed a 10 megahertz transducer, you had to switch transducers. Or if you wanted a 5 megahertz, you were constantly changing transducers, which meant if you wanted to do the full gamut of ultrasound, you had to have a lot of transducers, which is a lot of money, right? So the technology itself did not lend itself to be able to change your frequency on the same patient without having to change the transducer. In today's technology, we're using broad bandwidth transducers that have multiple elements. The majority of them are electronically steered and have electronic focusing capabilities, and they also have multiple frequencies with them that you can use. So within the range of frequencies that are in that signal, you are able to select certain frequencies on the same patient, same transducer. So you might see that your curvilinear transducer is a 3-5 megahertz. Depending upon the size of your patient, you can switch with just the push of a button to get to the frequency you need for penetration and resolution capabilities. You also have the ability to utilize transducers for multiple applications. For example, the sector phased array transducer specifically designed for cardiac applications, but you certainly can use it for abdominal. So there are some limitations to that. As you know, it comes to a really tight point in the center of the sector, so there are some limitations in field of view. But if you're on a budget, you can certainly use this transducer to do multiple applications, as well as your curvilinear transducer, mainly abdominal, OB-GYN, but we also have used that to get a limited cardiac or look at the lungs as well. So we have a lot more versatility with the transducer technology that we have available, and it allows for us to also be very innovative in our scanning techniques when we wonder, can we scan something and just give it a try? Like, who would ever think that we'd be using an endocavitary probe to look at peritonsillar abscess, right? So it happens. So let's just take a look at some of the evolution of the images. This was one of our first images, not mine, I wasn't born then, but this is images from one of the first static scanners that were developed. And you can first off see this, very contrasty, right? Black and white, that's all they had, 2 shades of gray. But it gave them the capability to still see inside the patient. And this happens to be an OB. And so this is the urinary bladder here. So we can see bladder. This is the placenta. We can see a low-lying placenta. We can look at the amniotic fluid, and this is the fetal head. So you're able to get some limited information, at least on fetal lie, placental localization, amniotic fluid, volume, etc. You see how these images look like they're just painted on? That's exactly how we scanned. When I started in 1979, I had the opportunity to initially learn on a static B scanner, but thankfully quickly moved into more current state-of-the-art technology. But it took a while for real time to really take off and for people to adopt that. But in static scanning, if you've never used it before, the transducer is here and it's attached to an articulated arm. And you would start on one side of the body and you'd sweep over the abdomen or OB patient, whichever you're scanning. Then you'd lift your foot pedal up, you'd move it up a centimeter, scan all the way over again. So it was like painting. And so it really wasn't art, because if you didn't get it right, you had to erase it, kind of like, you remember Etch-a-Sketches, or, you know, erase it and start all over again. And of course, if the baby moves, then you're going to be starting over as well. The other downside was that in these early systems, black and white, that's your contrast resolution, right? The more gray shades you have, the better contrast resolution you have, which gives you better detail to discern subtle changes in echogenicity that might represent pathology. That wasn't going to happen here, right? In the abdomen or in OB. But moving forward into the mid 70s, then you see that comparing this image to this image, there's a lot more gray shades, right? So this happens to be the liver, but you can tell it's a static B scanner because of the strokes that are being made to scan through the liver and the kidney. So here's your diaphragm, liver, kidney here. Still not a lot of gray shades, but you can see that there's enough gray shades to discern that there is some change in echogenicity representing some liver masses. Once real time became evident and or available to us, it was great because you could not only see inside, but it was very low frame rate. So the movement wasn't really catching up with your scanning, but you could actually see in real time. This is a fetal head here, and notice that it's that linear array that I showed you in the other image. It's that big, huge transducer. And as you scanned the patient, because the frame rates are so low, you had these artifacts that were like flicker artifacts. So you see all these lines going through the image. So you had to kind of see through that curtain of artifact to look at your images, but yet it was still a great advancement in technology. Comparing that to pretty current, like 90s technology, this is a curvilinear transducer, a lot more gray shades, a lot greater detail than what we can see back in the first real-time systems that probably had maybe 8 shades of gray if we were lucky. So the introduction of real-time really expanded the diagnostic capabilities despite lower resolution images, less grayscale, and lower frame rates. Well, I'm not going to leave out cardiac because cardiac was important, and you might think, well, how could they have possibly done cardiac way back in the 50s? But this was in 1953, and they didn't have 2D imaging, right? But we had M-mode capabilities. And actually, when I first started learning how to do cardiac as well, many of the hospitals that I worked in did not have 2D because it was early 80s. And so we only did cardiac with M-mode tracing. It's a little pencil probe about that big. You had to know the anatomy of the heart so that you could actually angle the beam to sweep through the various structures. But what you got was, back in the 50s, a very primitive tracing of the heart compared to what we have now, where we have more gray shades, we have a lot more grayscale, but we also have much better frame rates. The higher frame rates, your temporal resolution is what allows you to be able to see structures, dynamically moving structures as they are truly moving in real time. So we have come a long way. In the 70s even, I'm not sure how they processed these in the 50s, but I can tell you that when I was first scanning and we had to do a cardiac, what you would do is you scan through the heart, and as you're scanning, you have a foot on a foot pedal, and all this paper is coming out of the machine, right? But it's light sensitive paper, so you don't really, you know what you're seeing on the screen, you're not sure if you got everything you needed. You take that paper out, you go out in hospital hallway, and you throw it down the hallway and let the lights process that image. And then you'd roll it all up and you'd go through it and make sure you had everything you needed, and then you would manually measure it. Now we don't have to do that, right? We can do everything online. So things have really, really changed over the years. And so getting into the 90s and beyond, our technology has really led the way for the development of the smaller systems, expanded the clinical utility to bedside ultrasound and other POCUS applications, mainly because, well, a big part of it is the technology that we have improved image quality, higher frame rates, smaller systems, more portability. We can see so much more now than we could before. So, and that's not going to change. And then the introduction of color, power Doppler, spectral Doppler, all of these technological changes have opened up the doorway for us to be able to expand our clinical utility, do more exams across all specialty areas, not just OB and abdomen. So it was at this point in time where we're getting all of these new capabilities with our systems, they're becoming more portable, that we realize that ultrasound is not just for babies anymore, right? It's valuable for multiple specialty applications. And then the doorways just opened and boom, we've got bedside ultrasound. We've got the systems we can use. We have the image quality. That's great. And the capabilities, we have it in an affordable range where we can actually purchase these systems. Yes, they have less bells and whistles than our higher end systems that we use in the dedicated radiology and cardiology departments, but those are primarily for advanced quantification. And that's not necessarily something that's needed in the POCUS arena. So, and if you do need it, then you probably can borrow a system. But at any point, the technology we used to call mainly, I mean, we still use bedside and focused ultrasound, but POCUS is the current trend that covers a lot of different specialty practices, not just emergency medicine. So in the early 1990s is when really ultrasound in the emergency department started taking off. And of course, this was not without a lot of controversy, but the driving force for utilizing ultrasound was your trauma patient. So these were really the first areas where you could get acceptance across all specialty practices that this is a technique, a technology that's very useful and very needed in the emergency setting, despite the fact that the systems were still quite big and the image quality maybe not as great as we have right now, but you were able to get your yes, no answers as to what was going on with the patient. They have a hemothorax, pericardial effusion, hemoperitoneum. They could rapidly get that diagnosis and determine the appropriate management of that patient. And it was that utilization of ultrasound for trauma that really helped to set the stage for the growth of using ultrasound for many other applications in this practice. And so blunt trauma being the first, and limited emergency departments using ultrasound, they oftentimes didn't even use the word ultrasound when they needed the system. They just say, get the fast machine, or let's fast the patient. You might even still do that. But some of the first utilization of ultrasound in the emergency department really went through a process. And so there's a lot of literature that's been published, as you well know, and Europe was a little bit further ahead of the US and using ultrasound for emergency applications. But in the 90s, we started seeing a lot more articles that were US-based articles. And Dr. Ma Matir published an article in 1995 in the Journal of Trauma outlining an algorithm for using ultrasound in blunt trauma for both stable and unstable patients, showing a very high sensitivity, specificity, and overall accuracy. And I think they were trying to also emphasize that even though trauma ultrasound is something that can be utilized both in a level 1 and non-level 1 trauma centers. It's not just dedicated to that. In fact, it might be even as equally as important in a non-level 1 trauma center, because you can utilize that to help make decisions whether you need a surgical consult or transport that patient to a level 1 trauma center. So with all of this new literature coming out in the 90s, documenting and supporting the use of ultrasound, that just kind of opened the floodgates for expanding the use of it for other applications. So let's look at the who, what, where, why, how for POCUS. We know that focused ultrasound performed by the clinician at the bedside to answer specific clinical questions or guide interventional procedures. It can be performed by physicians, advanced practice providers, EMS, military medics, and other healthcare providers. Very, very helpful in the emergency medicine, critical care, urgent care setting, austere and rural environments, pre-hospital, private practice, and even cruise ships. In fact, you may or may not be aware that ASAP and the International Cruise Line Organization have collaborated together and developed ultrasound practice guidelines that's specific to cruise ships. And there is a requirement now in place that at least one physician on every cruise ship must be trained to do ultrasound by January 2026. So things are always changing, right? And so there's a new environment and new guidelines and new requirements. Pardon me? They have their, like the ASAP guidelines, you have your core applications. For cruise ships, it's much smaller scope of practice, primarily vascular access, and I forget what the other one was, but it's 3 primary applications to start. I'm sure that will expand, but ASAP and the International Cruise Line organization banded together. There's not a certification requirement. It's that you get trained in some capacity. They haven't said how, yes. Yeah. So looking at the why we do POCUS, obviously everyone here is very aware that utilizing POCUS helps to expedite your time to diagnosis and treatment, assess your response to treatment, and reduce potential complications when performing interventional procedures. And as Dr. Durr said, it definitely helps you to connect with your patient and really is a rewarding tool to use in your clinical practice. But even it's equally as important why we do POCUS is for patient safety. And in the end, it's going to also contribute to your patient satisfaction, but patient safety through reduced radiation, especially in your pediatric and your renal colic patients. There's been a lot of studies that have shown there's direct evidence of small but statistically significant increase in lifetime cancer risk at CT doses. And there's a lot of articles, as I said, that are out there. This is just one that demonstrates that the value or the sensitivity and specificity of ultrasound versus CT in assessing for renal colic and kidney stones is very equal to that of CT, but without the radiation. And so as a result of all of these articles and data that's been published, in 2013, the American Institute of Ultrasound in Medicine deemed that the year of ultrasound recommending that you use ultrasound first. And ACEP followed suit in 2014 and launched their Choose Wisely campaign, which stated to avoid using CT in young patients, with young being defined as less than 50 years of age, with known history of kidney stones and uncomplicated symptoms of renal colic. So the goal here is to use ultrasound first, try to reduce the patient radiation exposure, especially those that are very vulnerable, your pediatrics and your renal colic patients that you see quite frequently. I was particularly happy to see that because now, with young being less than 50, that means I'm now middle age. Yes. So the evolution of POCUS, as I mentioned, it's been a little bit of a battle to get acceptance. There's a lot of controversy, interdepartmental battles, especially between radiology, cardiology, who are the dominant departments performing ultrasound and still have their own role in that as well. So as part of, along with the literature, ACEP developing their ultrasound practice guidelines and policies help to really continue to get the acceptance across the board of using POCUS in the emergency setting. And I think 2013, when we had the year of ultrasound, is really kind of where there was a turning point, because the American Institute for Ultrasound, which is predominantly a radiology organization and OB, for them to come out and recognize the value was pretty important. So basically, they stated the goal is to increasingly integrate ultrasound education and use throughout all levels of healthcare professions and clinical applications. Dr. Mike Blavis, who's an emergency medicine physician, pretty well known. He was part of the first emergency medicine community within the American Institute of Ultrasound. And he also stated that we're seeing ultrasound adopted in every specialty now as a standard of care from A to Z, with the exception of pathology and psychology, is being used across the gamut. So this is back in 2013. Dr. Levon Nazarian, who is a very well-known musculoskeletal radiologist at Jefferson University Hospital, and also the editor and the chief of AIUM's Journal of Ultrasound and Medicine, he actually stated, not everyone in the global radiology community is wholly comfortable with non-radiologists performing ultrasound, which we know. The need for ultrasound interpretation in all fields is far greater than the current number of providers can sift through. Many have little interest or expertise in conducting these studies, and the solution, Nazarian said, is to open the door for other specialties to offer ultrasound as long as practitioners receive the proper training. Very important. So the Year of Ultrasound aims to increase the number of medical practitioners who successfully provide this type of imaging in the hopes that the modality be more frequently used. The bottom line, expanding the numbers who can do it will provide the best care to patients in the most cost-effective manner. And that was a turning point for the utilization of POCUS, when you can have radiology and cardiology and all these various departments come together and recognize the value of using ultrasound and the benefits to the patient, both in time to treatment as well as overall patient outcomes. So when we look at the use of ultrasound from a traditional perspective and POCUS, obviously traditional ultrasound is still here, going to be here for a while, forever, but it's for a different need. So in traditional ultrasound, the clinician requests the exam, it's performed by a sonographer, and it's submitted to the interpreting physician, whether that's a radiologist or cardiologist, to be interpreted. Whereas in POCUS, the clinician's performing the exam at the bedside, you're doing the scan, you're interpreting it, you're acting on those results immediately, you're adjusting your treatment accordingly, which takes seconds to minutes, right? Whereas for a traditional, you're going to request it, you got to wait, it has to be done, and then you have to wait for a report. That could be hours, could be days. And so time is of essence, right? So it makes sense that POCUS would be accepted across the board. Traditional ultrasound, more comprehensive. If somebody orders we have limited CPT codes for radiology departments. You can order a limited abdomen, which would be, or just a gallbladder or just a renal exam, but the sonographer is going to perform a complete exam. So they don't just do that area. They scan that as the primary area, but they still look at everything, which takes more time, right? Where at the bedside, you have a clinical question that's very focused that you want an answer to. Do they have a AAA or not, or so forth. So traditional being formal diagnostic image and POCUS being more an extension of the stethoscope in the physical exam. But there is one thing that is common between traditional and POCUS ultrasound, and that's the need for education. You need to have your initial comprehensive training, and then you have to have ongoing CME because this is such a dynamic profession. As you can see, just in the technology from not all that long ago, the 50s to 90s and beyond has changed so much. And what we can do with ultrasound has also changed so much. So if you're going to be doing ultrasound, you've got to have a mindset that it's a continuous learning process. And that's where ACEP's model curriculum in the 1990s is when early 1990s was first published. And there have been many updates to that, with the most recent revision being in 2023. And developing that model curriculum, the ultrasound policies, guidelines for emergency departments to follow has been very helpful in that successful adoption into clinical practice, and also has assisted other specialty practices to integrate ultrasound into clinical practice, such as critical care, anesthesiology, musculoskeletal, family medicine. They're in the early stages, about where EM was, but you've all paved the way for everybody else. And so the other specialties are even able to utilize emergency medicine guidelines to help develop their own ultrasound practice guidelines and kind of streamline them to what their specific needs are as well. So kudos to emergency medicine. So the ACEP guidelines state that the primary clinical utility for POCUS in the emergency medicine is resuscitative, diagnostic, procedural, symptom-based, or therapeutic. And when the ACEP guidelines were first out, there were about 9 core ultrasound practice applications, and then there was an advanced level applications as well. And over time, in fact, I think it's just 2023, these areas that are highlighted in yellow were moved over from advanced into the core applications. So we went from 9 to about 15 applications. And although some of these are a little bit more technically challenging, the fact of the matter is these are applications that you're going to use on a day-to-day basis. And so it's important for you to learn them right from the get-go. And so that's the reason why they were moved over. So some of them are a little see one, do one, teach one. Ocular is not too challenging to learn, but nerve blocks, they would be a little bit more technically challenging, but they have been moved over to the core applications because of patient need, pain management, and also as a contributing factor in the opioid crisis. So obviously we've come a long way, baby. And not only in technology, but also in the evolution of medical education, because as these technology changes and POCUS was adopted, we had to integrate ultrasound into that medical curriculum, right? So we know that the technological changes, the new applications, all of those things are all operator dependent, and they do require initial and ongoing continuous learning. And we've seen throughout the years here now that most emergency medicine residency programs have integrated ultrasound into their curriculum. Not all, but many medical schools are integrating it as an early introduction of the technology. And of course, we have our fellowship programs as well. So it really has expanded over the years. So you want to make sure that when you're doing your education, that wherever you get it, at medical school, residency, ultrasound fellowship, attending physicians, not all attending have got ultrasound in their residency. So that means you got to go outside the scope to get your hands-on training. So you just want to make sure that if you're in that capacity, whether you're trying to add that skill set to your clinical practice or you're wanting to expand your skill set to another area, that you have both didactic and skills training. The hands-on training is so critical. You can take as many online courses and sit in as many lectures as you want, but you're not going to be able to perform those exams without getting the skills training. So that is a very, very important aspect of it. And I know time is important. So you can also do may not want to go to a traditional format course that has lectures and hands-on all combined in one, there's blended format programs that are available. That way you can do your online education at your own time and then coordinate either a private hands-on or have a group training at your facility or go to just a hands-on blended type of program. We offer all of those at Gulf Coast, but there's plenty of opportunities for you as well. My big thing is I call it the friends and family plan. You got to scan, scan, scan. It doesn't matter who you scan. They don't have to be real patients. These handheld systems are very versatile, right? You can scan yourself. You can take it home, scan scan your family. The more you scan, the better you get, the quicker time that you'll take. It won't take you as long to do an exam. You'll see your image quality getting better and better. And then don't forget that you can take this all the way to getting registered. You can get registered through the ARDMS or APCA. You can also go through the POCUS PCA Academy, the POCUS Academy. They have some certifications there as well. So there's many different pathways that you can take your training to if you choose to do so. So in summary, POCUS is here to stay. It's not going anywhere. In fact, it's just going to continue to expand in its clinical utility. There's still a critical role for traditional ultrasound services. That's not going to go away either. There's a time and place for both. Obviously, technological changes with system portability, quality images, costs have allowed emergency providers to go beyond the physical exam. And it's so great to be able to actually see inside the patient, see what's going on in real time so you can make that rapid decision for your patient and have the reward of knowing that you were able to have and improve patient outcomes. Your patient's going to love you for that as well. We have in our family, we have a standing rule that if something serious happens to us, well, I've already said first, if you can get me there, take me to Tampa General. But but there are certain places I don't want to go because I know they don't use ultrasound yet. And it's hard to believe that. But if you're not using ultrasound in the emergency department, shame on you. So we know that POCUS is proven to be beneficial to all specialty practices. It's more widely accepted, and there's going to be ongoing improvements in technology. We already have AI, right? It's not quite where it needs to be. It's helpful in some capacities, but I can assure you that AI is going to change the way that we practice with ultrasound as well. And with each new application, it's going to expand our diagnostic capabilities, but it's also going to require us to continue learning. So at this point, you're probably going, oh my God, I'm just starting out here, and you're going to get this list of applications that I need to learn. I don't know if I'm ever going to be able to get through all of those, but you will. And you have all of you that are here, you have great leaders. So you will have no problem with that. But again, you just want to master the core applications, scan, 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 family and friends plan. And then once you've become more confident and proficient in your core applications, then you can expand those skills to doing the more advanced and challenging applications. Start with the easier to do ones, fracture, ocular, things like that aren't have a steeper learning curve as more advanced cardiac applications do. But that's going to get you to the end result of getting through and learning more and more applications. And I can assure you that at some point, you're going to be evaluating, assessing a patient, and you're going to be thinking, I wonder if I could scan that. And the answer is yes. How do you think we got to all these other things? Is someone thinking, could I do that? And they try it and it works. And then we move on to accepting that as an application that is highly adopted. And so ultrasound, out of all technologies, I think you're going to find is very exciting. It's rewarding, not only for you, but for the patient as well. And so the more you learn, I think what you're going to find, if you haven't already, because I know there's a wide variety of people in the audience here with different levels of experience, but the more you learn in ultrasound, the more you're going to want to do. And that is for sure a fact. And so I encourage you to learn as much as you can and to have that excitement about POCUS, because it truly is a game-changing technology to use. So I think this video kind of nicely summarizes that concept, that it's not complicated. More is better.
Who thinks more is better than less? Okay, why? more is better than less, because if stuff is not if there's less stuff, then you might want to have some more, and your parents just don't let you because there's only a little bit.
Right.
We want more. We want more. Like, you really like it. You want more.
I follow you.
So make sure that you can provide more, integrate those core and advanced POCUS applications into your skill set, and provide more for your patients. Thank you.